It's my pleasure to introduce Dr. Akanksha Sharma. She is a triple board certified neurologist, neuro-oncologist, and palliative care specialist who serves as director of neuro-oncology at California Pacific Medical Center. And she is a recognized leader in patient-centered neuro-oncology care and has dedicated her career to improving quality of life for patients and families facing brain tumors. And Dr. Sharma, thank you so much for joining us today, and we're grateful to have you here. Look forward to learning from your expertise. So I will
Thank
turn
you.
it over to you.
Thank you everyone for joining today. This is really an honor and it's an exciting opportunity for me. I really love when I can talk with families and patients and clinicians all together, because that's not an opportunity I get often. And so I always try to find more ways to do that. I've done that through the ABTA and the NBTS in the past, and it's been really fun. So I'm hoping to have an engaging discussion today, and not so much me telling you, but answering your questions about palliative care. I will have a few slides, and I think when I walked in, there was a really good question from Lori. And I just want to tell you a little bit about me, more than what David said, more as a way of kind of clarifying this question about hope. So I've been doing this about 10 years now, which feels like, it doesn't feel like it's 10 years, but when I decided I would be a neuro-oncologist, I decided that I had to do palliative care because it made most sense to me that there were gaps in patients' cares and caregivers' care that I couldn't fill, and my mentors didn't know how to fill. And so part of my desire to do palliative care came from that, recognizing those gaps and realizing that we needed to do better for our patients, and we needed to do better for our patients at every stage of their journey, whether it was diagnosis or recurrence or late in life. And but back then it was not a very popular concept, or even less so than now. More taboo in terms of fear and what that means, and it was really equated so I was actually strongly discouraged by a lot of people of combining those two. And people would often say things like, oh, well, how are you going to give people care? How are you going to put them on trials? Very valid concerns. Someone once asked me, like, are you going to put everyone on hospice? And it was confusing to me back then, because for me, the way I viewed care was, someone is walking in my clinic with a really significant, serious illness that has completely changed their life, has turned things upside down. They need support from me more than ever. And they need support from me in every aspect possible. And here's a tool that will help me, teach me about how to take better care of their symptoms, how to talk to them better, how to help them understand their disease better, how to think about the future. And so why would that conflict? But now over time, I realized that it conflicts because our mentality, it conflicts when our mentality in care becomes disease centered. It conflicts with this idea of focusing on the disease. It doesn't necessarily conflict with the idea of person-centered care. But when you just think about the GBM, how am I going to treat the glioblastoma? How am I going to offer more treatments? What if the person stops treatments because they realize it's not helping them? Then it conflicts with that. But if I'm looking at the person living with the disease and I think about all the ways I can support, then I find that it doesn't conflict. And the way that I've demonstrated that is that I'm not just a palliative care specialist and neuro-oncologist, I'm a clinical trialist. And I was head of clinical trials at the last institute, John Wayne Cancer Institute, for a couple of years. And now at Sutter, we run an integrative palliative care program, which has palliative care integrated from day one, and clinical trials as a very big part of that. And I see palliative care really as providing goal concordant care. And we'll talk about that a little bit. But there was recently, one of my patients was featured in the SF Chronicle, and one of the joyous things about that was he described me as this positive, hope-filled feeling that came into the room. And that was more about the idea that what I'm sharing, and when I'm talking about all the hard things that come with life and illness, the goal is not to take away hope. And if you do it well, my theory is that you won't take away hope. Hope will change. Hope should always change. And hope does not have room for delusion. And we'll talk a little bit about that in my brief presentation, then go back to our conversation. This is a talk I gave at the ABTA, and is a quick plug. The American Brain Tumor Association's National Patient Conference is in September. And I'm co-chairing it, so of course I'm biased, but we're trying very hard to make it focused on the patient journey. And so there'll be a lot of topics on the journey, integrative medicine, palliative care. and also clinical trials, AI tools. Just we're really trying to focus on how we can make things easier for patients as they're walking through their journey. And so the questions we've already sort of talked about palliative care, and I think a lot of you seem like the difference makes sense in terms of what is palliative care and how is it different from hospice, but we'll review it again. And I want to tell you a real story, and I have permission to talk about Ben's story from Ben. I'm very fortunate to know Ben. He's a software engineer. He was 8 years ago. He had no medical problems. He was just married, and he started to develop problems with balance and numbness of the tongue. And he has a family history of neurological illness. And so he went and talked to his PCP, who said, there's nothing going on, don't worry about it. But Ben is a huge advocate for his own care, and he insisted that he wanted to get an MRI. And his MRI showed a large pontine glioma. So this is what we called back then and still called DIPG. And there is a variant of DIPG called diffuse midline glioma, which comes with a specific mutation called H3K27M. At the time, he saw a lot of surgeons. He saw some of the best surgeons in the country who said, we can't really get a biopsy of this. It's going to hurt you, and it's inoperable. So then he again advocated for himself and found a blood test. And the blood test showed H3K27M mutation. So he had diffuse midline glioma of the pons. And I'm going to tell you more about his story. But before I do that, I just want to tell you the way I view the patient journey is that I break it up in these processes. So when you're first diagnosed and you go through your first phase of treatment, then you go through recurrence, and that recurrence could happen 1 year, 6 months, 2 years, 5 years, 15 years, hopefully. And then there's a later stage where you have gone through multiple recurrences and are starting to experience these different symptoms and questions. And nearing towards end of life. And then I consider the post phase of when someone passes from brain tumor, the bereavement phase, to be a phase that we need to be involved also and learn and support our families. So when I think about Ben's story, I didn't know him back then, but I'm sure the questions he wondered was, how will radiation affect me? Will I feel worse? Will this affect my thinking and memory? Will I always feel anxious? Will I have panic attacks? How do I manage the depression that comes from having this diagnosis at 31? Can we still have kids? Who will support my wife? How do I work? How will I get disability or not? How will we make this work? And they were living in one of the more expensive places in the country. And then, of course, the spiritual aspects of why me? How much time do I have? What will happen? And so these are all sort of the ways I think about the different aspects of care that patients can be impacted with, and when they're diagnosed with a brain tumor. So Ben goes through radiation, 6 weeks of chemotherapy. He had a lot of symptoms. By the end of it, he was using a walker. He had difficulty with swallowing. His speech was really slurred. He had significant hair loss, and his swelling in his brainstem was so significant that he started Avastin for radiation necrosis. And at that time, through his own advocacy, again, he found that there was a drug that they were studying in a compassionate use drug program. And he's tried to get on a trial for it. He wasn't eligible for the trial, and so he found a compassionate use program, and he traveled to Washington to get on this experimental drug. So at this point, he is just post-radiation, still in that initial phase, but he's wondering about the fatigue and the headaches and the weakness and the hair loss. He started to have a lot of cognitive issues from radiation. He was really terrified. Would he be able to make his own decisions? How will his memory be affected? How does he manage, again, his anxiety? His sleep was really disrupted. His wife and him were navigating this with some support from friends and family, but all this navigation and figuring out trials was all something he had to do himself. He was on disability, but there's always the stress of, will that go away? What about my insurance? And then, of course, the future, like, again, the aspects of why me, why us. And so let me now bring into this what palliative care could have done and what we have done, because I've known now Ben for 5 years. So palliative care is the multidisciplinary pursuit of quality of life. And I like this definition because it has nothing to do with timing. It has nothing to do with diagnosis. It's just, I like to think that I could use palliative care in many, many periods of my life. It's alleviating suffering, and in serious illness where there is a lot of suffering, it improves quality of life and it reduces suffering. How does it do that? It does that because when we go through palliative care training, even if it's a brief training, not necessarily a fellowship or board certification, we learn that these needs need to be addressed in a more holistic fashion. They can't just be focused on the disease, on the chemo, on the imaging, on the lab. We need to think about the person who's living with the disease and think about how this disease is affecting them and how their needs need to be addressed. And apart from that, it supports both the patient and the care partner. The care partner is often somebody that we don't consider as part of that organism of care and we need to consider. Does it mean I'm giving up? Does it mean that I'm giving up hope? Well, no. According to the research, patients who received palliative care felt better. They had better mood, less stress. They better understood their illness, which means they could get care that was more concordant with their beliefs, and they could communicate with their family and medical team better. They spent less time at the hospital, and then the trials all from advanced cancer demonstrate that they often lived longer. That has not necessarily been true yet in brain tumors. But I would argue that in brain tumors, it becomes more important to consider what kind of life rather than just how much life. And so there was recently an early intervention of palliative care trial done, a randomized clinical trial that was done in Germany. And patients who were in the intervention arm did not live longer. In fact, they had a little bit less survival. But when they went back and they looked at it, they realized that these patients knew very clearly what their line was, and they knew what they wanted and did not want to know, and they felt better supported. They had higher quality of life. They had less depression, less anxiety. And when the time came where a doctor was like, would you like to do X, Y, and Z that carries this amount of risk? They said, no, thank you. And so it did seem initially on first glance, oh, they're living shorter, but then you go into it and you realize, but actually we're helping them understand how you live is as important as how long you live. So how is it different from hospice? In the US, hospice comes in at the end of life. Palliative care can be at any point. It does not need a terminal prognosis, which is often a misconception. It can be outpatient, it can be in clinic, it can be sometimes home-based. It's like seeing any other specialist. The palliative care person is supposed to fit into your team. And if you don't have a palliative care specialist in your area, you want doctors who understand palliative care, who are trained in it. It's concordant with everything else they're getting. It should not be something that's separate. I often will be in tumor board and people will say, okay, there's no more treatment, we can do palliative care. What they actually mean is hospice. Hospice is when you've run out of treatments and you're nearing end of life and you have less than 6 months according to Medicare. But in the US, we don't do concurrent treatment except in the veterans and pediatric populations, and hospice is a covered benefit in most insurances. Palliative care aims to be life affirming and life valuing. So again, as I said earlier, like it matters how you share this information, how you introduce palliative care, and what kind of palliative care you provide. But by and large, it is life affirming and should not be seen as something that takes away people's hope or has them consider less on treatment. Instead, what we're aiming to do is build resilience, build coping, and make sure that the treatments being offered are in line with what the patient wants for themselves. It is true, though, that there will be hard conversations. In palliative care, we see death as a natural part of life. And of course, death is a natural part of life, whether we like to think about it or not. And so it does have less death phobia. We're not uncomfortable with death as palliative care providers. We also recognize that it matters how you live and how you die. And so that aspect of making sure that patients have dignity, are not suffering, and are as comfortable as possible are part of that palliative care lens. Palliative care, these are Nathan Gray is an amazing palliative care physician who does fantastic cartoons that help clear kind of all the language around palliative care. But these are 2 posters he made that are like national park posters, but it's interdisciplinary support, lighting a path through the landscape of serious illness, or interdisciplinary support with patients navigating the peaks and valleys of serious illness. And so there are interdisciplinary people in a palliative care team. It could be a physician, such as myself. My team, for example, which is built on this palliative care model. I'm very fortunate to have an amazing nurse navigator whose shadow you can see in the back right there. She supports me in every aspect. I have a fantastic social worker. I have a wonderful advanced practice provider, and I'm hoping one day that I will have a chaplain. So those are part of my team. I also work with the psychologists and counselors in the Sutter system. We work a lot lot with rehab services, and then none of this would be possible without the support that makes day-to-day possible with the medical assistants, administrative assistants, and research staff. So this is part of the interdisciplinary team that's possible. Not everyone has that, but generally this is what you would like in an ideal world. And they're working together to support you and looking at it with every lens. So for example, with a recent patient, we thought about, okay, here's his medical treatment right now. How is he doing emotionally? How is his wife doing? How are his parents doing? And the social worker reached out to make sure they had resources. My nurse navigator made sure that all their appointments were coordinated with their chemo and other appointments, or if we had to fight insurance, that we were doing that. So all of that kind of works together to make sure that care is less burdensome. It's part of the ideal patient experience. This is something we wrote last year for brain mets, so patients who had brain mets, and palliative care is right there in the side, but equal part of this whole structure of social work, medical oncology, neurosurgery, etc. What kind of ways can it help me? So I've kind of talked about it a lot already, but the communication piece is the foundation of palliative care. And it's built around high quality communication, making sure that we communicate with our patients. And in these kinds of settings where we're dealing with outpatient chronic conditions like neurological illness or neuro-oncological illness, it's done slowly over time. It's not something that we kind of throw everything in one visit and so the patient gets overwhelmed and scared, but really trying to spread out all the things we need to do together to help them face their disease, which is managing their symptoms, making sure that their care is coordinated, thinking about the future, spiritual support, social support, shared decision making, and understanding their disease and coping with the disease. We also have to make sure that the caregivers are in the same place, because research shows that care partners of patients living with brain tumors have higher levels of distress. That's because patients often will have higher dependence, higher needs. It can be very isolating and lonely because it's still a rare tumor, even though it doesn't feel rare. And there's discordance in how patients and their care partners understand their disease. And that's what some of my research work is focused on, that prognostic discordance. And I note in my practice every day that it contributes to a lot of tension and distress in the family. So as we think back to the things that Ben was thinking about, if I had known him back then, these are how I would split up all his worries, right? He was having a lot of symptoms, so we'd want to make sure that he manage his symptoms. We explained to him that part of the thinking and memory changes are from radiation and they will get better. Some of them may not get better. Let's see how we can help you cope. Let's get you in with neuropsychology. Let's get you in with speech therapy. We're making sure that he has decision-making support about should he go back to work or not? Does he need to file for long-term disability? What support system does his wife have? If he doesn't have support systems here, does he need to move somewhere where there's support system? And then thinking about the future in that way. Again, this is in follow-up. If we think about, again, if he's worried about his coordination, like how do we plan for what might happen? At this point, he had been given about a 6-month prognosis, but how do we live with that 6-month prognosis and think about the future? So how do you access palliative care? It can come from your team. It can come from a request, from a family member's request, or there are a number of organizations now that recognize the value of palliative care and can help you get navigated. And so including getpalliativecare.org. Anytime is a good time for palliative care, but you can also engage palliative care when there's more symptoms, when you're more worried about the future, when you can't understand where your disease is growing, and when you're having trouble navigating healthcare, or you're frustrated that your care isn't well coordinated, or when your family needs more support. I have patients who have benign tumors who just need help with figuring out how they live with this disease, where are things going, or they want their neurosurgeon and their radiation oncologist to have a conversation and understand that they're both on the same page. So sometimes a lot of what I do is really helping my patients and their care teams be on the same page. Those are all fine reasons to involve palliative care. So let's get back to Ben's story. So Ben just did an interview last year on This American Life that you can listen to, where he talks about some of the challenges he had navigating this as a young man. But this is Ben's MRI now, many years later. The drug that he fought so hard to get on worked, and he's now one of the longest survivors on this drug, which is now FDA approved, called Modesto. He now has 2 little girls. This is a picture of his 2 girls when they were much younger, and I'm glad that he is here and spending time with them as they grow up. And together we continue to navigate issues. We think about the long-term effects of radiation now. We're fortunate to be able to think about that. We think about his cognitive changes. I help him do paperwork for his disability. We're thinking about survivorship and things like, do we need to worry about his cholesterol and all these things? And so planning for the future and survivorship also falls into my viewpoint as somebody who is his palliative care doctor. So that's kind of my take on palliative care. I hope that that was helpful and also hopeful. And hopefully I'm stopped sharing my screen. Did I stop sharing my screen? But I'd love to take questions and go back to our discussion and so that I can stop talking.
Well, thank you, Dr. Sharma. I think those last few slides really resonated with many of the questions we received before today's session. One of the most common question was like a variation of when is the right time to involve palliative care, right? And based on what you shared, it sounds like the answer may be earlier than many people expect. Could you expand on how patients and families can start the conversation with their care team, if palliative care hasn't been offered?
Yeah, that's a really good question, and I see some of these points in the chat too. So, a few years ago, I was fortunate that the National Brain Tumor Society had these two roundtables that was funded through the Patient Care Consortium grant, and we had 60% patients and caregivers on this table, and we were talking about, well, how do we improve care for patients with brain tumors? And one of the topics that came up resoundingly was palliative care. But a lot of families came up to me and said, I never knew that was an option, or I was too scared of it as an option, or no one even brought it up to me. At what point? So all these questions that you're saying. So this continues to be a problem, and we are working really hard as a field to change it. I think I've dedicated a lot of my career to trying to educate other neuro-oncologists and younger trainees. And so hopefully as that disseminates, people will start offering it themselves. We just had a conversation this morning with a lot of younger neuro-oncologists where many of them are automatically saying, hey, would you like to consider this service called palliative care? If they don't offer it, when is a good time? I think anytime you're feeling overwhelmed and your team and your team might be fantastic, they might be excellent in a lot of ways, but you're like, they don't talk to me about prognosis, for example, or I really am curious about what options I have if I want to stop treatment, or I really want to know how I can live better. So anytime that you feel like your needs are not being met and the team is not able to address it, you can definitely ask for palliative care. Most cancer centers now have palliative care. That's one of the requirements. And so it might be someone, a nurse, advanced practice provider, a social worker, but it's a starting point. Or you can, as I said, look up on some of these tools online. And I think for people who are early in their journey, it's again always a good time to get people with palliative care involved. And I have had situations where people have asked for palliative care and the oncologist has said, no, you don't need that. And I would say that my other hat is just empowering patients to say, well, no, I have pain that's uncontrolled. I want to make sure that that's addressed. It's very personal to me in a lot of ways. I've had loved ones who've had very advanced cancer who have not received appropriate management. And so it's very painful to me when I find that that's happening. But again, I like to empower patients to make sure that they ask for what they want. Should I answer some of these questions in the chat, David?
Yeah. I wanted to first go over just like another major theme that we heard from caregivers. So, you also mentioned that caregiver often experience significant distress, isolation, and uncertainty. Like, what are some ways palliative care can support caregivers even when the patient is still doing relatively well or actively receiving treatment?
Yeah, great point too. So I always think that if my caregiver is not doing well, my patient's not going to do well. So I see them as part of my team. I'm part of their team. They're part of my team. We're all on this team together, team patient. And so how I involve them is one, I do when I start off people's care, I often check in and with the patient and say, hey, there might be times where your loved one has different needs or they have different questions. Is it okay if I check in with them sometimes separately? I've never had a patient say no. And so I will do that at the end of visits, call them after their phone call. I'll check in and see what's going on. But from other practices, I've also known that social workers do that, or nurse navigators will do that. But sometimes patients call and they don't realize that that's something that they can ask for, is like getting some one-on-one time with me, or just asking questions. So that's one way, because a lot of times the burden and distress is just coming from like, I'm noticing these different things at home and I don't know if I should bring it up in the appointment or not, or like how can I get a better understanding of it. The other thing, big aspect is support groups. Not everyone's ready for support groups day one, but I find that especially care partners who join support groups really find it beneficial. They find a community. No one will understand your journey as someone who's walked in those same shoes. And so I provide them with the National Brain Tumor Society support groups, ABTA, all of these number of resources out there that they can join virtually, or their institution might have a local support group. I do find a brain tumor specific support group is helpful because it's so different, as many of you already mentioned, than other cancers, especially from the cognitive and the neurological aspects. The Brain Tumor Network offers excellent free navigation services, social work services. And so that has been really an amazing resource that I've sent a lot of my patients to, especially when I didn't have my own big team. But patients have really loved that, and they're someone that they can call. Some patients want to have a face-to-face in person, and so for that, the cancer center social workers are great. So there are resources that are out there that might be unique to your area. Another one is cancer support communities in the local area will have social work support and nursing support. And then psychologists are another way. I often will encourage care partners to consider grief therapy and starting it early. And it's not grief therapy to prepare for end of life. It's really like you've lost things. Your relationship changes. You're mourning the change of a relationship. You're mourning the stress that you never thought you would have. So you can have both things be true, that you can be hopeful that this will get better one day, but you can still work on techniques to help you. And again, if people have found a good grief therapist, I've been amazed by how much that's helped them cope.
Thank you. Yeah, and then we also have a question from a caregiver whose mother's care team tends to view palliative care as something reserved for the end of life. They're interested in meeting, with palliative care earlier. I know you've covered that, it's definitely recommended to
Yeah,
advocate for yourself, but yeah.
if your team is saying, especially if you feel that you need it, I would say that one way is to also just reach out directly to the palliative care office and request that if they have any thoughts on how. I mean, if you're experiencing it, chances are the palliative care team is experiencing that there's a challenge in the burden of care, and they want to address that need from both sides. The other thing that people have done is found palliative care providers in their community. And now insurances also have realized the value of palliative care. So they are definitely, you can call the insurance and say, hey, I would like to find a palliative care provider that's in my network in my area, even if they're not in my hospital, and start there.
All right, thank you. And I'd like to open to the audience. If anyone else has a question they'd like to ask directly, that hasn't, already been answered, please feel free to either just come off mute or, place your question in the chat.
So, David, I have a question while we're waiting. So, Dr. Sharma, we presented a poster at ASCO that, of course, it wasn't rocket science, but it was data that came out of our survey that care partners were 3 times more lonely than the patients themselves. And are you seeing that, will insurance companies pay for care partners to get
Really good question. And a
therapy?
lot that people ask me when I give this talk, like clinicians say, oh, well, the reason I'm not doing it is because I can't get it covered. And
Yeah.
actually, they can. It's just prolonged time billing. So it's really, and that's another area I try to help educate people, is that it's education on billing is needed more than education on not being able to do it. Now that billing might change. We weren't able to bill on time until about 2021, and now providers and clinicians can bill on time. And so we can essentially talk to the patient and then spend 20 minutes later in the same day talking to the loved one and bill for it. It's not huge amounts, but it's definitely means that you're getting something for your time. The other thing is that social workers and nurse navigators who see providers for support, patients and caregivers for support can also bill. Now, does that mean that sometimes patients might have a copay? Yes, it might be $20, $30, but I find that most people would rather do that than paying, out of pocket for a therapist. And so I think there are ways that it can be done. It's not ideal. I definitely wish that the system was better, the system incentivized clinicians better. I mean, one of the reasons why I'm sure a lot of you are thinking, why isn't every care like this? And it's because it's expensive. And systems don't want to invest that level of money because the gains are not short term, they're long term. Long term, people do better, long term, communities do better, but everyone wants to see short term gains.
Yeah, from any advice from a nonprofit, it was actually really interesting because, Jason Binder really well, and he came by our poster and he's like, yeah, he goes, nobody invited me to a picnic the whole time my wife was sick. That was his comment to our poster, and it was just so relevant, and it's,
Yeah, that's so powerful. Yeah. I mean,
yeah.
and I think that people get so uncomfortable. I recorded a podcast yesterday with one for the neuro-oncology podcast with one of my patients' wife, who is a nurse who happens to be a CEO of a hospital. Her husband is a neurosurgeon who has glioblastoma. And the level of loneliness that they experience is incredible. It's more than I think other patients, because especially for other neurosurgeons and physicians, it was very uncomfortable to be in the same room as some of this. And so I can only imagine, like, that's hard for everyone. But the people who showed up really, and they mattered so much. But yeah, it's an incredibly isolating journey.
Hey, Dr. Sharma, I
Yeah.
have a question. Um, so I have actually a couple of questions. If you wouldn't mind sharing the name of that neurosurgeon, because I have never heard of that before. It's okay if you cannot. And on the topic of loneliness and isolation, what if somebody has no caregivers, and they get a brain tumor? Like, what are their options?
Mhm. Yeah, beautiful, beautiful question. So yeah, the surgeon is actually somebody who works in our group. His name is Dr. Mimran, and he has decided to stop treatment. So the podcast, I think, will come out at the end of the month. It's on the neuro-oncology podcast. I'm happy to share the link, David, with you. And she will share a lot from her experiences. He decided, because he has aphasia, that he does not want to be recorded, but he has been very open with his story, so that if it helps anybody. But he's been living with GBM for 3 years. So the question you asked was can you repeat that second part again that you asked, because I got distracted thinking about my.
Oh, no, it's all good. So, on the topic of loneliness and
Yes.
isolation, what if somebody has no caregivers and they
So
get
when
diagnosed with a brain
have
tumor?
caregivers, that is
Yeah,
honestly one of the hardest, for
yeah.
most neuro-oncologists would say this. Those are some of our hardest cases.
Mhm,
Fortunately, it does not happen that often. I can count on my hand, like both hands, like the number of times it's happened. And
mhm,
it's been very, very challenging, because um, and that's what helps me realize, like, how much of the framework or the infrastructure is set up by family and friends. In those cases, we usually have to end up getting them their insurance or some way to, especially if they're not Medicare or Medi-Cal eligible, it becomes even challenging, because we have to find a safe place for them. We have to make sure that they're basically nursing facilities or private caregiving, or find every way to find artificial caregiving, or not artificial, but paid caregiving. And that's very challenging. I remember one case I had where they were just rotating through caregivers because the person did have finances, but every caregiver was focused on, like, how can I get this money when she passes, rather than like the care of the person. And so
right.
fortunately, we live in a challenging world where that's true too. I have seen situations where people have been estranged and this has brought them together, and people have shown up even though they haven't talked to each other in 20 years, and they've shown up.
Yeah.
More recently, we had a case where the whole family was estranged. He was straight in a nursing home. I couldn't offer treatment because there was no one to bring him to treatments, and things moved very rapidly. So it's well known in a lot of cancers that lack of caregiver leads to worse outcomes. in brain tumors, it's incredibly strong. In fact, it's not reported well because those patients don't even get counted. Because sometimes even to get a diagnosis, you have to have a caregiver who recognizes that something is wrong.
Thank you.
Yeah, thank you. And thank you, Victoria. So Victoria in the comments asked, beyond support groups, what resources are available for brain tumor caregivers? Many caregivers are looking for guidance and support beyond individual experiences and online communities. What resources or types of support do you recommend?
Yeah. So I think for the caregivers, Jason Binder came up. Jason Binder is a care partner of someone who lived and died from glioblastoma. When he was going through his journey, he had a background in pharma and a lot of tech. So he actually developed an AI chatbot, which he worked with a lot of physicians on, including I provided the palliative care literature. So it's not like ChatGPT for help. It's a caregiver focused chatbot called Ember, EMBER. And it basically is somebody you can talk to in the middle of the night, on the weekends, like anytime, to say this is what's happening. It will always direct you. It has a safety like setup so that it directs you back to your provider, but it will say like, oh, this is really hard. Like these are the questions you should ask. And so I found it really helpful. I also have a family member now with glioblastoma, so this is personal to me. And so I use that also for myself because I find that helpful. But that's one resource. The other is just connecting with the brain tumor network, navigators, all these different organizations that exist, Mozilla Foundation, our brain bank. There are a lot of organizations that offer more than support groups. So one of the things, for example, they'll offer, I will get connections from the NBTS to say, hey, someone's looking for a second opinion. They're looking for thoughts on palliative care. So they will sometimes direct you to the person you need, rather than you having to figure it out yourself. So sometimes people don't realize that exists. From the other aspect for caregivers, I think, is local activities. So this is something I've learned more and more, but I have a lot of interest in how people develop resilience and resilience and coping mechanisms. And both for patients and caregivers, I recommend activities outside of their caregiving. So that is very hard to do. And most people, when I bring it up, will say, are you crazy? And I get it. It's really hard. But even if it's a small thing that you're doing once a week, but having that as some place that you can go and not be a caregiver for 20 minutes or 30 minutes, or maybe it's a mindfulness practice. But these are the ways that I also support our caregivers in terms of like ideas to do that.
One more suggestion and another way to plug the ABTA. Dr. Sharma, I saw you speak at the ABTA conference in September. The ABTA has a mentoring program for both survivors and caregivers. So that is another suggestion for both survivors and caregivers. It's a wonderful program. They will match you, and so that's another suggestion to get support.
Erica, you've been amazing.
Yeah, and I'll also just comment on the Ember help, and we can maybe put that in the chat or follow up, because I've used it quite a lot as well. And it's been evolving a lot, and and it's free to anybody who wants to use it. And Jason has done a wonderful job of continuing to feed information into it. I've found it very, very useful in helping put this very complicated disease into layman's terms. Especially like you come back from a visit, and there's all these terms you have no idea what they are. You can just put it into this GB. It's like it. I don't know what it's called. Like he's been changing the name, but it's called Ember Health now.
It's Ember.
Yeah, it's Ember.
Yeah, it's
now.
called Ember. Yeah, and it's just like you can just say, hey, like, what is this? And it'll put it in layman's terms. It's very empathetic. And so I would we can put that in the chat, because I do think it's something.
Patients
And I also highly encourage. I know somebody from Brain Tumor Network's on this as well, but they're a very, very, very good resource for second opinions, clinical trials. They have nurse navigators. And one of the things about the whole brain tumor nonprofits, we all work together. If you can't tell, we all we all try to plug each other's resources, because it's the one thing we all know is together we're so much better helping each other out.
Yeah,
So
I can plug a few more practical resources. The ABTA is great. Immerman's Angels does a mentoring, which is fantastic. If you're an Optune user, the Optune Buddy program, people have found really helpful for. It's NovaCure sponsored, but it's patients and caregivers, and so for caregivers of Optune patients, I think the point you make, Kelly, about not just Ember, but tools like Ember have been really important. So using AI for good, and so that's why we decided to do a session on the ABTA meeting about that, because there's a lot of ways you can do it. I do not recommend putting your health data in ChatGPT. I've had people doing that,
Exactly.
which they've found it useful to like tell doctors updates. But there are other apps that are being developed that are much more secure and not selling data. So keep an eye on that. But I strongly recommend people continue to use some of the older things too, like Caring Bridge or meal trains or things like. There's ways that you can coordinate your care, and a lot of new apps are coming out that help you do that, which you can say, okay, for if you have 10 people who said I'll be willing to drive, like call them out on it, send them out and be like, hey, here's a way to sign up. One of the things that we talk about in the podcast that is decision fatigue. Like, don't have people tell people like, I don't want to make decisions. If you want to bring over meals, just coordinate it with my friend. So one of the other things I tell caregivers is like, people are hesitant to ask their friends and family for help sometimes, but helping and giving, I mean, the reason Kelly and David and all these people do it is that it makes us feel good. And so even in that small community, it makes you feel like you're doing something. And a lot of times people step away is because they don't know what to do. They're like, okay, I don't know what to do. It's uncomfortable to just stand there. But versus if they were like, my husband is one of those people, one of our friends was dying of cervical cancer and he didn't know what to do. But if I was like, you need to go and make sure that her meds are there, and you pick up the meds from the grocery store, you get your food from the grocery store, we have the meds, he knew exactly what to do, right? So some people are task oriented. And so those are important ways that we can kind of help support.
Yeah, thank you for that.
Can I ask a question? Hi, my name is Sue Long. I heard you on a podcast and I just saw this on Instagram. So I'm really a newbie on this. My mom was diagnosed with glioblastoma a couple of months ago. She just started radiation. She's had 4 sessions. But the memory has been an issue for about a year. Like, we started noticing it, we started talking to her about it. She really resisted anything. And my father was dying at the same time. So we sort of put it on the back burner. So I think she's actually had it for a lot longer than she's been diagnosed. And she's 82, so I recognize that the loss is different than someone who's younger. But she's otherwise healthy, but she does not know she has the brain tumor. She doesn't know. Even though we go to radiation, she doesn't remember that's why we're going. And I'm having a really hard time figuring out how to talk to her about it. And on the other hand, it's not that hard. I just tell her again every time. But my question is, what we went through palliative care with my dad, but I don't know what to expect now. Like, she's got the memory issues, but that's it. She's not in pain. She's just like, what is going to happen and how fast? And no one will tell us. And I understand you're not supposed to give a prognosis to someone that you haven't even seen, but like, is her body going to start shutting down? Like, this is the kind of information I'm finding it like kind of impossible to find. Like, what is next going to happen?
Yeah, thank you so much for Susan for sharing that. Firstly, I'm sorry that you're going through this. My heart, I mean, that's so much loss and challenges together. The other thing, good for you for like recognizing all the aspects that were kind of tied together. Sometimes it's relieving to know, even though it's painful. I want to comment on one other thing you brought up before we go. So this happens often where people don't remember, especially as things get advanced. And one of the things that we see in high-grade glioma, so for glioblastoma, grade 4 glioma, is that sometimes patients become more optimistic. Not everyone, but I've definitely noticed that. Some of my research has been based on that, is to recognize that they lose insight or they don't remember. And it's protective mechanism, maybe. I also think it's actually related to the tumor because the tumor likes to grow in dopamine-rich areas. But all that to say, people have said, should I remind them all the time? I think that I follow the same philosophy that we do in other kind of neurodegenerative and memory issues. Like if it's not bothering them and if it's just going to cause the same trauma again and again every day, I would say you don't need to, unless it's affecting the way you care. Like if you say, hey, we're getting treatment for what's going on, and she's not asking a lot of questions, just leave it at that. You don't have to feel responsible for her to understand every aspect of her care, because that's just very difficult for you. It's difficult for her to go through that every day. And then the second point you bring up, one of the reasons I became a palliative care doctor was that no one would talk to me about how patients with brain tumors pass. I had to learn that myself. None of my mentors knew. There was a survey done many years ago. Hopefully it's different now, but 50% of neuro-oncologists did not know how patients with brain tumors passed, what end of life looked like. Like 5% of neurosurgeons knew. And so it's an area of a huge lack of information. Part of it is, again, this death phobia. I can tell you generally this, I agree, this video is really good. I saw it myself and I was like, oh my God, this is so great. But this hospice nurse talks about what happens at the end of life. But I think in general terms, it is different than a lot of other cancers because people will get more and more sleepy, more and more tired. There will be more memory issues. There will be more weakness. And in most patients, especially older patients with glioma, death is not from the tumor directly. It's from the complications caused by being more weak, more sick, not eating. And so what happens in this process is that it's what I call 1,000 different cuts, at which point you have to say, okay, no more. Like she doesn't want to go to the hospital. We don't want to do anymore. And then you focus on having her be comfortable and having her, and then those natural processes like infection or not eating. And it's not like hungry and I'm miserable and you're not feeding me, but it's just like you start shutting down and not feeling hungry. Those are some of the things that kick in. There can be seizures. There can be episodes of agitation or confusion. And so it is important. That's why it's so important to me that experienced hospice be involved at that point. But depending on the patient's condition, where they are, it could be months. I had one patient who stayed on hospice for a year. And so everyone's a little different, but I definitely encourage you to look at some of these videos. Please feel free to reach out to me in terms of any support that you might need. And David can share my email with you.
That's really nice.
Yeah.
Thank you.
Yeah, thank
It's
you. And
we're trying to educate. I do a whole session on how people die with trainees because it's just, they haven't seen it.
thank you. Yeah, and we're just about at the end of our time, and I want to thank everyone for all their thoughtful questions and participation. And thank you, Dr. Sharma, for sharing your expertise with us today. And thank you to everyone who joined and contributed to the discussion. And we will be sharing recording with registrants and as well as the resources that we have discussed. So I will send a follow-up email with everyone. And I hope everyone has a wonderful day. And we hope to see you at a future GBM Voices event.